بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله أجمعين. Some of my conclusions are the same as Dr. Firas, and I have never seen him before, so don't think that we kind of have some agreement behind. So what I'm trying to talk about today is try to talk in general about the evaluation of pulmonary hypertension, but focusing more on left heart disease. So I started the clinical case. Actually, I saw this patient just a few days ago, and I performed a right heart cath on last Wednesday, just one day before I came to Jeddah, which I think it highlights a number of points that I'd like to discuss. And she is a 61-year-old woman who's known to have obesity. She weighs 133 kilograms. Her height is 159 centimeters with the body surface area of 2.29. She has diabetes, hypertension, atrial fibrillation, and she's known to have heart failure with the preserved ejection fraction. She also has history of PE in the past, and she's known to have pulmonary hypertension over the last couple of years. About a year ago, she was seen by a cardiologist who started her on sildenafil based on echo findings and was referred to our center for further evaluation because she continues to have symptoms of shortness of breath class 3. Some time recently before she came to us, she also had a coronary angiogram, which basically revealed no obstructive coronary artery disease. Her medication admission, Lasix, 40 milligrams twice a day. She's on perindopril, 5 milligrams, rivaroxaban, atorvastatin, 10 milligrams, sildenafil, 50 milligrams twice a day, and pantoprazole. On admission, her PMB is over 2,000, about 2,300. So this is her echocardiogram, and I'd like to highlight a couple of things here, the things that I shaded, and they're really very important. Specifically, look at the comments on right ventricular function and size. Look at the comment on elevated pulmonary pressure and pulmonary regurgitation. So what's the etiology of her PH? Could it be just because of heart failure? Is it mainly because of heart failure, but other contributing factors are contributing to her pulmonary hypertension? Or is heart failure a wrong diagnosis? And this patient, basically, she has either chronic thromboembolic pulmonary hypertension or she has idiopathic pulmonary hypertension. So what should be done next? I think we'll take you to a journey of how to evaluate these patients. My objectives from this talk is actually to address a number of misconceptions, specifically with echo, and this is actually was addressed by the speaker before me and the right heart guy. But also, it's a little bit sad that I have been doing this stuff for a number of years, and always I have problems with the echo and the right heart caths that are performed by ourselves as cardiologists. So I try to really take you to what really expect from a good echo or a right heart cath. Also remember, pulmonary hypertension is not a diagnosis, it's a hemodynamic observation that needs to, basically you have to find a diagnosis for, or a cause for etiology for this hemodynamic derangement. And this is why I put what diagnoses are associated with pulmonary hypertension. It's not this, because it's not a diagnosis. And Dr. Firas actually went through these classes, but what I'm trying to do is basically I want to remind you that don't forget that some patients, they have multiple etiologies that coexist together. So although we are dealing with heart failure, so you have to remember that heart failure patients, they have comorbidities. For example, COPD and sleep disorders are not uncommon in these diseases. DVT and PE are not uncommon. Again, diseases from the first group, like toxins. We see patients that become young patients with captagon-induced cardiomyopathy, and we know that amphetamine-like drugs can cause pulmonary hypertension. Connective tissue disease like scleroderma can cause restrictive cardiomyopathy, and so on, like portal hypertension, congenital heart disease can coexist. Furthermore, thyroid dysfunction, especially hypothyroidism, is not uncommon in all patients. In fact, 24 to 25% of patients with pulmonary hypertension, they have hypothyroidism. So this has to be kept in mind. And also, renal disease on dialysis is another cause of pulmonary hypertension to remember. And always remember the pathophysiology and the underlying hemodynamic definition of pulmonary hypertension that Dr. Firas has spoken about. Specifically in heart failure, you can have post-capillary, isolated post-capillary pulmonary hypertension, but also you can have mixed pre- and post-capillary pulmonary hypertension, and this can be sorted out in the cath lab, not by echo. So another basically note is actually regarding the severity. I always see in echo cardiograms, pulmonary pressure of 60, severe pulmonary hypertension. Severity cannot be determined by just the level of pulmonary pressures. And Dr. Firas has told you that in advanced disease, in fact, pulmonary pressure goes down. So although the patient has severe disease, but his or her pulmonary pressure is lower than somebody with less disease. So right ventricle is the central in this basically disease. And degree, the severity also depends on the degree of anatomical and pathophysiological abnormality, as well as degree of functional limitation. So you have to integrate all these factors together to decide whether a patient has severe disease or not. So first, I think every patient with pulmonary hypertension, heart failure pulmonary hypertension, has to have assessment of functional class, 6-minute walk test, and if you have access to cardiopulmonary testing, I think it should be done. Laboratory testing, basically guided by the underlying history and physical examination and basic findings, and I will leave that. But let us just go into echo and Doppler. So what echo Doppler study should give you and should provide you about a patient with pulmonary hypertension? So it should estimate PA pressure. It should give you an assessment of LV and LV systolic and diastolic function. You have to rule out valvular heart disease, rule out congenital heart disease, assess PH consequences on RV, and also I think echo has a role in providing you some information, especially in difficult cases when you have normal ejection fraction and you're wondering whether this patient has HFpEF or has pulmonary arterial hypertension. If I have time, I think I will go through that as well. So what are problems with current practice? Improper assessment of PA pressure, especially in terms of RA pressure assessment, which is integral part of measuring the PA pressure. We use arbitrary grading of PH severity based on PA pressure, and I have mentioned that. We use visual assessment of RV size and function, which I think is completely wrong. And we ignore some important findings, like, for example, RV to acceleration time, which provide you some really important information. So as Dr. Firas mentioned this before, so basically you use TRJ to measure the gradient between RV and RA, and then you add RA pressure, and that basically gives you the estimated systolic pulmonary arterial pressure. Now, I think most labs, they added a 5 or 10 millimeters as an estimate to right atrial, and they don't really use other methods of actually assessing and estimating right atrial pressure. One of the most common ways of estimating RA pressure is actually to use the IVC size and collapsibility. And I think every lab should have it maybe somewhere on the wall to remind the techs and also the interpreter. But basically, you can go to the algorithm and find out. It goes from 5 to 20 millimeters. At this point has been addressed by Dr. Firas, and that's basically echo provides you with an estimated PA pressure. It provides you with the likelihood of a patient has pulmonary hypertension or not, and does not really give you a diagnosis, and you should confirm that. So where is the sources of error when you estimated PA pressure? One of them is basically wrong placement of the cursor. Sampling after PVC, for example, it can overestimate. Overestimation of RA pressure, and also in patients with atrial fibrillation, you can actually under or overestimate PA pressure. In fact, just going back, 50% of patients who have echo and have right heart cath, they will have a difference in PA pressure of at least 10 millimeters, either up or lower. So 50% of patients, they're going to get wrong assessment of PA pressure by echo. Acceleration time, I think it provides you a very important, I don't know, is the, this is a pointer. Okay. So having a late systolic notch or mid-systolic notch, actually very highly specific, and it correlates very well with PVR of more than 3 Wood units. So if you have somebody with a notch on the pulse Doppler wave in the RVOT, you know for sure that they have underlying pulmonary vascular disease. So structural and functional consequences, you know that RV and R get dilated with pulmonary hypertension. So just visual assessment and telling me that it's dilated, severely, moderately, or moderately severely dilated, I don't understand what that means. And this is why we have to really use some kind of quantitative assessment. One of the easiest way of quantitatively assess the dilatation and the enlargement of RV is in fact actually just using diameter ratio at the base of the RV and LV and you can grade it from mild to moderate to severe based on the ratio RV to LV ratio. Furthermore, you can actually take the cross-section and you look at the eccentricity index because of flattened symptom, you can actually measure the long and the short axes, and you can actually come up with an index that actually predicts also even outcomes. It can also differentiate the short axis, parasternal short axis views when you have a dilated RV and you're not quite sure that's volume or pressure overload, it can actually help sort that out. So assessment of RV function, RV is notoriously difficult chamber. It has irregular borders. It has a difficult shape. If you look at it from basically the side, it looks like a triangle. If you look at cross-section, it looks like crescent. It's very difficult to measure volumes. Endocardial definition is not as good as the LV, and also the contractility pattern of the RV is completely different from the LV. And this is why it makes it difficult to assess RV function. So most people, there is qualitative visual assessment, which is really poorly correlates with quantitative measures, and it should be completely abandoned. Fractional area change is difficult because, again, it's equivalent to LV ejection fraction, but just using right ventricular area from the four-chamber view, it's difficult because of poor endocardial definition. So the most common used parameter which has been studied and it correlates with outcomes is the Tapsee, which is the tricuspid annular plane systolic excursion. And there's some data also on tricuspid annular velocity from TDI. A number of other parameters that I'm not going to go through because they're not standardized and we don't have enough data. So Tapsee is basically using an M mode at the lateral portion of the tricuspid annulus, and basically it's very simple to obtain. Unfortunately, most of patients that come out from the cath lab not having Tapsees. We know that the normal Tapsee is ranging between 23 and 26 millimeters. If you have Tapsee less than 20, indicates RV dysfunction, and you can actually grade it. But we know that specifically patients with Tapsee of less than 15 millimeters, they have very advanced disease and they have worse prognosis. The TDI, tricuspid annular velocity, we know the normal value is above 12. If you have a patient with pulmonary hypertension and they have S-wave less than 10 centimeters per second, that actually indicates worse prognosis. Now, right heart cath, this is the dearest, I guess, topic for my heart. And basically, why we do right heart cath? Number one, we confirm diagnosis. We document hemodynamic abnormalities, some of which are very important in terms of prognosis, like cardiac index, like RA pressure, like PE saturation. It helps in difficult diagnosis, for example, with HFpEF versus PAH, and restriction and constriction. And also, we'll perform vasoreactivity tests, which is important for starting calcium channel blockers or indication for calcium channel blockers. But let us just, this is in general. You have patients with heart failure. Which patients that maybe you should send for right heart cath? Because we are dealing with class group 2 patients rather than group 1, which is a little bit different. But any patient that you consider for pre-transplantation, I think they should, for sure, they have to have right heart cath. To differentiate between HFpEF from PAH, when restrictive cardiomyopathy versus constriction is in question, and when other etiologies coexist. For example, you have somebody that may have congenital heart disease or CTEPH, and if you are contemplating using targeted treatment for pulmonary hypertension, you should not start it without obtaining right heart cath. So Dr. Firas went through this. Basically, a complete right heart cath should have all pressures and PE saturation or mixed venous oxygen saturation and measure of cardiac output, as well as vasoreactivity, and I will leave that. So again, I'm just reconfirming, or I'm emphasizing the point that Dr. Firas made. Heart cath is essential. It's not a complementary test. No patient should be started on targeted therapy before performing right heart VRT. Common problems with heart cath, we have lack of attention to quality, and this is very important. We have complete reliance on digitized readings, and I can tell you that the majority of cath labs are using that. We ignore respiratory variations. We fail often to take, mixed venous oxygen saturation, and we improperly use exercise and fluid challenge hemodynamics. So we have to ensure proper system setup, leveling, zeroing, adequate damping conditions. We have to set the pressure scale and paper speed at the right level. I'll show you an example, for example, of a right atrial pressure at scale of 50 and speed of 25, and at scale of 20 and speed, and you can see much better the waves and you can do better measurements. Similarly, this is with an RV tracings at 200 scale because the patient has pulmonary hypertension, and at 50 scale, and you can see the ADP much nicely. You can determine the ADP nicely. Now, in terms of cardiac output, for most patients, thermodilution is enough. You have to obtain triplicates of cardiac outputs. If there is variation of more than 20 or 15%, then you have to resort to FIC method. Similarly, it was discussed in the morning about low cardiac output state and severity or congenital heart disease. I think FIC is the way to go. Proper heart cath is also, we have to ensure that all required data are obtained and recorded before leaving the room because you don't want to go back. We have to pay special attention to pulmonary artery wedge pressure because the entire diagnosis depends on it, and the differentiation between post-capillary and pre-capillary pulmonary hypertension depends on wedge. If you are in doubt, have low threshold to go for an LV-ADP measurement. I think you have seen this in the morning. I'll skip that. But let us say that the recommendations do not use digitized numbers, especially for the filling pressures, because you can get it wrong. And we have to use actually either printed or even you can do it on the screen, and you have to use the end expiration measurements to make sure that, why we use end expiration? Because end expiration where the intrathoracic pressure is equal to nearly equal to atmospheric pressure. So you have, unfortunately, with inspiration, a fall in pressures, and we have to only, for example, look at this example of one of my patients with significant respiratory variation. The main pressure, of wedge comes to 14, which tells you that this patient has basically pulmonary arterial hypertension, which is completely wrong because the A wave is higher than that, and actually the true wedge is 20 millimeter of mercury. So completely different diagnosis you can obtain. One study that looked at this, comparing the digitized pulmonary wedge pressures versus end expiratory wedge pressures versus LV-ADP, and you can see the poor correlation between the digitized and the LV-ADP. In fact, in this study, they used average LV-ADP, and I'm quite sure if they used end expiratory LV-ADP, it would come similar to the wedge, although there is no significant difference between the two. So other common pitfalls, partial occlusion of the balloon can give you overestimated pulmonary arterial wedge pressure, and also over-wedging is another problem because it can give you overestimated pulmonary arterial wedge pressure. Now, misclassification of pulmonary arterial hypertension based on wedge has been studied. There's at least 2 studies. One is very large that has 4,000 patients, and in this study, 53% of patients who were diagnosed as PAH based on wedge, in fact, they have group 2 pulmonary hypertension with an LV-ADP of more than 15. So let me just go back to the case because, as I mentioned, I think it highlights a number of things. So the first, this is RA pressure, and you can see this is just a little bit high speed. She's in atrial fibrillation, so there is no A waves. You can just the C wave, and you have a rapid Y descent, and there was no respiratory variation. It's like a Cosmol sign. Now the RV pressure is between almost, it goes to about 64, 65. And when you take it at a scale of 50, you can see actually better the ADP, which comes about 24, 25 millimeter, which is equal to the RA pressure. Now, you go to wedge. So I tried to wedge a couple of times and I could not get good wedge. Eventually, I have to do it with the breath hold, which this is not what we recommend, but sometimes, as long as you know what you are doing, then patients are not taking a Valsalva, and they're doing just naturally, you might be able to get the wedge. But, and again, it's really high. It's about 24, 26 millimeter of mercury, which is equal to RA pressure. And immediately when you see this, you really have to think about constriction and restriction. And because also I wasn't really quite confident, so I went and punctured the artery and did actually LV. And this is simultaneous wedge with LV, and you can confirm that actually my wedge was right because it coincides with the LV EDP. And one thing here that you can notice that there is no respiratory variation, which indicates that there is no dissociation of the intracardiac and intrathoracic pressures, which goes with more with restriction. Again, this is just I took an RA and LV, and you can see equalization of pressure between RA and LV. And again, this just points to restrictive physiology. And this is RV and the LV. You can see when you take it that this is for EDP kind of correlation, and this is just to look for concordance. And you can see quite clear concordance, which also points to restrictive cardiomyopathy. Now, this is just a summary of the pressures. You can see that there is high filling pressures on both sides, pulmonary hypertension, and you can see that here blood pressure is actually not well controlled. So there's restrictive physiology, and here PE-SATs is 80.9. So immediately this tells you that she has a shunt. It cannot be, whenever you see a PE saturation over 75% or above, then you really have to think about that. So basically, I took my multipurpose catheter from the left side, and I went and probed for the ASD because, and I found some surprising findings. Number one, there is anomalous pulmonary veins drainage. Both the right middle and the right upper pulmonary veins, my pointer, okay, that's okay. So in the left upper panel, and you can see, and the two upper panels actually in the pulmonary veins. And then I went to SVC, and actually, I don't know why I did that. I wanted to see what's going on, and I found actually that she has persistent left SVC. So yesterday, on Thursday actually, we sent her for CT scan and confirmed presence of anomalous pulmonary venous drainage, persistent SVC, and sinus venosus ASD, but there was no unroughing of the coronary sinus. So multiple etiologies can coexist in this patient. So what I did in this patient, because of high filling pressures on the left side, I gave her nipide infusion, started at very small dose and went to up to 8 micrograms per kg body weight, which is really very high dose. But I was able to bring the pressure down to about 110, 120 systolic, but I could not drop her filling pressures. The lowest EDP I got is about 18 to 20 millimeters. So it tells you that she has a very stiff ventricle. So final message, pulmonary hypertension is not a diagnosis, and I'm just reiterating what Dr. Firas is saying, and echo should be done properly and reported properly. Right heart cath is essential to confirm the diagnosis and should always be obtained before considering PAH. And I think these patients should serve it better in referral center. I'm not quite sure if there is a minute or two. There's no time. Huh?
Okay, 1 minute.
Okay, just a couple of things in terms of PH versus HFpEF. I think clinical parameters are important, like old age, hypertension, obesity, diabetes, AFib, are all goes more with HFpEF than PAH, pulmonary arterial hypertension, I mean with PAH. And echo findings, for example, LA enlargement, LVH, abnormal LV filling, and increase in RV, apical angle, and notching are basically data that you can use to differentiate between the two diseases. For example, if you have somebody with open angle, wide angle of the apex, and they have very dilated RV, that goes more with PAH, with basically pulmonary vascular disease. If you have somebody with pulmonary hypertension but narrow angles, small RV, that goes more with pulmonary venous hypertension. And the presence of notching, as I mentioned before, correlates really significantly with increased PVR, which is expected in PH. And usually in HFpEF, unless they have significant precapillary disease, they have a rounded, well-rounded actually envelope. And as people, they came up with a score that basically goes from -1 to -2 to +2, basically, based on presence of left atrial enlargement, presence of increased EA ratio, presence of notching or lower acceleration time. And basically, you can actually, for example, this is an example of a patient with HFpEF, and you can see they have enlarged LA, they have abnormal prolongation of AA ratio, and they have rounded, well-rounded envelope on the pulmonary, on RVOT pulse Doppler. On the other hand, in this patient, for example, the patient has normal or smaller LA, they have normal filling pressures, and they have notching. This actually significantly indicates that this patient, 99% they have PH and not HFpEF. And sometimes you have mixed kind pattern with presence of abnormal LA and presence of abnormal filling, and you have basically notching, which indicates that this patient likely has HFpEF with also pulmonary vascular disease, and I won't go into in terms of right heart cath. Thank you.